We're excited tonight for the Known Well in the Know. You're here at the Known Well in the Know webinar, in case you're not sure where you're at. I'm Dr. Angela Fitch. I'm the co-founder and chief medical officer of Known Well. And I'm here tonight with one of our amazing Texas nurse practitioners, Faris Kayssi. Faris, welcome to yes,
Thank you.
exactly. Faris,
Yeah.
we got it. Everybody clap.
Yes.
We're going to present tonight. Faris is going to take us off and lead us off with some information regarding patients and our male patients. And then I'm going to jump in. And for those of you that are female patients out there, uh, we will talk about how our hormones affect our metabolic health and longevity. So I am going to let Faris kick it off here shortly. But first, remember, there's a Q&A box here on the webinar. So please put any questions you have in the Q&A box as we go, because at the end, we will have time for questions. So please do not hesitate, and welcome to those that just joined. I'm Dr. Angela Fitch, co-founder and chief medical officer of knownwell. You're here at the In the Know webinar, where one of our amazing nurse practitioners, Faris Kayssi, is going to take us into a discussion on metabolic longevity. Faris, why don't you kick us off?
Thank you so much, Angela. This is so much fun. I'm so excited. So hello everyone. I'm Faris Kayssi, nurse practitioner here in Dallas with knownwell. I'm glad to be here with you today. So as Miss Angela said, we're going to talk about weight, hormones, and muscles and how they all connect, help us live longer, stronger life, and and this is what we call the metabolic longevity. Um, all right. So if you've been online, you've probably seen a lot of confusion or even contradictory claims that weight loss medications eat away your muscles, or that you need testosterone therapy just to lose fat. So today, we want to clear that up. There's solid science on weight loss medications, testosterone, and protecting something really important, which is your muscle. The big idea I want you to walk away with today is that this isn't just about losing the weight. It's about building a body that stays strong, healthy, and capable for as many years as possible. And that's what I mean by the metabolic longevity. So for men specifically, these are generally the three things that work together to determine your metabolic health. So your body fat, your hormones, especially testosterone, and your muscles. So think of these like the three legs of a stool. If one changes, it affects the other two. Body fat isn't just an extra weight sitting there. It actually becomes or behaves like an endocrine organ. It produces substances or hormones that affect inflammation throughout your body and even changes your hormone levels. So what happens when we carry extra fat, especially around the belly? That fat tissue produces an enzyme that actually converts your testosterone into estrogen. Your body then senses that estrogen is high, and it mistakenly tells your system to slow down testosterone production. So the result is that your testosterone drops, which makes it easier to lose muscle and easier to gain more fat, and then the cycle keeps feeding itself. And this is one of the facts that I found, that just a 4-inch increase in waist size raises a man's chances of having low testosterone by 75%. So that is the hormonal equivalent of about aging 10 years. And it was a survey actually that was done in Boston. And this here shows us, what that you know that not all low testosterone is the same or created equally. So sometimes it's a true medical problem with the testicles or the pituitary gland, but very often in men with excess weight, it's what we call pseudo hypogonadism, meaning the testosterone making equipment or the system still works fine, but extra fat and extra visceral fat converting that testosterone into estrogen. In these cases, jumping straight to testosterone therapy treats the symptom, but not the actual cause. The better first step addressing is to address the weight itself. So this is where medications like GLP-1s come in play. So think of Zepbound, Wegovy, similar medications like GLP-1s. As we lose visceral fat, the deep belly fat that we have sometimes, that testosterone to estrogen conversion process slows, way down. So then your body gets the correct signal again, and now your natural testosterone production often bounces back on its own. In many cases, this means men can avoid needing lifelong testosterone therapy altogether simply by losing the weight that was suppressing their testosterone in the first place. When we lose weight, the scale can't tell the difference between losing fat and losing muscle. Studies show that weight loss in general, up to 25% of that you lose, it can actually be lean mass, not just fat loss. Losing lean mass isn't just a cosmetic issue. It can, damage your metabolism long term, if we're not doing it the right way, that is, and make you more frail as we age and get older. That's why our goal isn't just to see the number on the scale go down first or fast. It's to lose weight gradually in a way that protects your muscle. I like to call, your muscles your metabolic armor. So your muscle is where your body processes blood sugar and many more other things. So more muscle means better blood sugar control. Muscle also burns calories all day long. It's actually a big reason that men naturally burn 500 to 1,000 more calories per day than women because they generally have more muscle mass. If you lose muscle while you're keeping your body fat, your resting metabolism can drop significantly, which makes it easier to regain weight down the road. So protecting your muscle is one of the best things you can do for long-term metabolic health and longevity. So if we want to put this all together, think of it like a pyramid. So the foundation, as you can see, is the biggest, most important piece, which is lifestyle. So healthy calorie reduction, enough protein, regular strength training to help your body hold on to muscle and build muscle if you can. The middle layer, as you can see, is medication support. So like GLP-1 medications that help control hunger, reduce inflammation with some of them. And at the very top, with men, you see that only when truly needed is testosterone therapy a precise tool that we can use after confirming that it's actual true hypogonadism. So this is a very interesting study that I found that I want to share with you guys that was done here in Texas at the Houston VA Medical Center. In 2024, the study looked at 83 older men, 65 and older, who had obesity and consistently low testosterone. So the researchers wanted to know, if adding testosterone therapy on top of lifestyle and exercise and diet does it improve health even more than diet and exercise alone? So that was the big question they wanted to answer. So both groups, they split the participants in two groups. So the ones doing lifestyle changes alone and the ones doing lifestyle changes plus testosterone. And they saw major improvements in blood sugar control and lost about 20% of their harmful belly fat, or what we call the visceral fat. So adding testosterone didn't really improve blood sugar or fat loss any further, which is very interesting. So the group that did the lifestyle changes alone actually saw bigger improvements in their good cholesterol or HDL and the protective hormone that we call adiponectin, which is one of the hormones that protects our hearts, reduces inflammation, and improves insulin sensitivity. The more fat tissue we accumulate, the less adiponectin we start producing. So it's a very fickle balance. So the takeaway here is that testosterone is not a magic weight loss pill. Diet and exercise are still doing the real work for your heart and your metabolic health and longevity. So, but also what they found in that study, it was an interesting finding that they saw that the testosterone, the people who took testosterone, it actually protected their muscle. The lifestyle only group, the group of people that did not take the testosterone therapy, they lost about 2.4 kilograms of muscle, while the group that used testosterone with lifestyle, they only lost 1.2 kilograms, so roughly half as much. So the bottom line is that testosterone therapy isn't a fat burning tool. It's a targeted tool that can help protect your muscle and bone while you're losing weight, but it needs to be used at the right time for the right reasons. So at knownwell, we don't take testosterone therapy lightly. Before we consider it, we confirm that it's a true deficiency with at least two separate morning tests. We look for real symptoms like ongoing fatigue or low sex drive that don't improve with weight loss. So first line is still, lifestyle therapy. Go through a training program and nutrition program, and then we check and make sure that it's safe for you to be on testosterone therapy. So this is generally the steps that we kind of go through. So step number one, we look beyond the scale and figure out whether low testosterone is a true medical issue or something driven by weight. Step two, we build your foundation with a structured, supervised plan focused on protein and strength training. If appropriate, we add GLP-1 medications to help break the cycle. And one thing here that I always talk about with all my patients is sleep. How is your sleep? If there's sleep apnea, we address that too. Stress management. And then we add testosterone therapy only if it's truly needed to help protect your muscles and bones, only if it's a true hypogonadal state. So this is my portion, and these are the references that actually list that study that they've done in Houston. So yeah, if you guys have any questions, be more than happy. And now Dr. Fitch is going to take over.
Thank you, Faris. That was wonderful.
You're
You can go to the next
welcome.
slide. I'm going to cover the women now.
All
Um,
right.
There we go. Women's health and hormones, right? That's what we're going to talk about a little bit because we talked about men's health and hormones there. Unfortunately, during the menopause transition, the average weight gain for midlife women, regardless of a race or socioeconomic status, is about 1.5 pounds per year. And if you think about the menopause transition can occur over a 10-year period, that could be 15 pounds of weight gain, which is tends to be all fat, unfortunately. We're going to see a graph on that in a second. So again, we see this happening, right? And this is the staging of the menopause transition, right? So this is the staging of women's reproductive transition. Really, we start with uh, our reproductive years, right, when we're having regular periods. Then we get into the early perimenopause when our cycles tend to become irregular. Then we have late perimenopause, is where we're having more than 60 days of changes, in our cycle. And then we have what's called our final menstrual period. Unfortunately, we don't know like when that's going to happen or how to predict that. But whenever the final menstrual period happens, then we go after that as we define that as early postmenopause and then late postmenopause. The late go back there a second. Faris, you're getting, there we go. Thank you. The late perimenopause to early postmenopause window, it's roughly 2 years before and 2 years after the final menstrual period. So that time there is the steepest metabolic change, right? 2 years before and 2 years after. When we gain fat mass, we lose lean mass that Faris was talking about, right? As we're talking about protecting those muscles, right? We have changes in our lipids and we have vascular markers that change most steeply during that time to increase our cardiovascular risk. All right, now go ahead. So the scale though hides that shift as Ferris was talking about, right? Because it really, we have 2 times the rate of fat gain at the start of the transition. That's 1.7% per year fat mass gain during this transition. And this steep change during that 2 year, 4 year window, essentially 2 years before, 2 years after. And because lean mass is going down and fat mass is going up, oftentimes the scale doesn't change very much, but that's really not, measuring what we need to measure. And that's why we check body composition in our clinic, to really look at what is, what are we, how much fat do we have? How much muscle do we have? What is the components that make us up? And so for women, we go from, unfortunately, in the premenopause state, this sort of what we call gynoid shape or pear shape, right? Where some of we have tend to have more subcutaneous fat in our hips, in our buttocks, in that area. But our visceral fat, that belly fat that Ferris was talking about, is about 5 to 8% of our total fat. But then after we go through menopause, unfortunately, that shifts where now our visceral fat is 15 to 20% of our total fat, and it's a more central storage. This is mediated by estrogen in particular. Estrogen restrains visceral deposition when we have good levels of estrogen in our body when we're younger. It keeps it from depositing in that area. And then that decline over time during the menopause transition is what then shifts that storage into our abdomen. And this just shows us, right, that is sort of graphically, right? So in that 2 years before and 2 years after, that steep rise in that visceral adiposity, unfortunately, right? And then it plateaus off. And then the green line is our lean mass loss. So as we age as well, we have some loss in our lean mass. Now we can prevent that by doing some strength training, and that's what we're going to talk about in a little bit. That visceral adiposity or that abdominal fat, right, is what really drives what we call cardiovascular kidney metabolic disease, right? Which is this visceral adiposity drives insulin resistance, atherogenic dyslipidemia, which means changes in our cholesterol in a not so great way, that chronic inflammation that Faris talked about, hypertension can develop. And so we have this increase, what we call CKM or cardio kidney metabolic risk related to not only our heart disease risk, but risk to our kidneys, and then that risk to our metabolism, like type 2 diabetes. And 50% of postmenopausal women unfortunately meet the criteria for metabolic syndrome, which is this constellation of these things. So midlife is the inflection point where preventable risk becomes established disease. And so that's where we're trying to catch this earlier for patients and talk about it earlier so we can really, help to sort of prevent some of this from happening. Lean mass loss matters metabolically, as Ferris mentioned, not just in women, but also in men, right? If you lose that lean mass, you lose the muscle mass, that can lower your resting metabolic rate, how many calories you burn. As Ferris mentioned, men tend to burn more calories than women because they tend to have more muscle mass, right? And that muscle is a metabolic engine that burns that glucose, right? And then when you don't have as much muscle mass, then you have reduced glucose disposal. Your body doesn't use sugar the way it should, and it can then build up and accumulate as fat mass. You can have declining strength and function. We want to really reiterate that as it relates to not just about losing weight, but gaining health, right? We want to gain that health that is that strength and function. This is not just about mass. You can lose some lean mass and you can be stronger. Strength is not necessarily directly related to mass. If you have more mass, you tend to be stronger, but the vice versa is not true. You can still have strength even if your mass is decreased a bit. So again, we want to really focus on strength and function, how you feel, not just a number, on a scale or a number that we're measuring, but how do you feel functionally? And again, with loss of lean mass, women in particular can have higher symptom burden. When you have lower lean mass, it can be associated with more vasomotor symptoms of menopause and metabolic abnormalities we talked about, right? As it relates to the fact that your muscles, if you don't have as much muscles, then you're not burning as many calories, and then those that can add up and be accumulated in that visceral adiposity in your stomach. And we can't stress enough that skeletal muscle is a metabolic organ, right? And that's what we're trying to focus on both for our men and our women patients. So resistance training is the highest yield lever that you can pull during that perimenopause or during that menopause transition. You can increase muscle mass, you can and really, decrease your fat mass, change that body composition, maintain your waist circumference. This is me doing some squats in the gym, and really, adding that resistance training is what can really help you to maintain that muscle mass over the course of time. And you don't want to start out like this. You want to, get a trainer, find somebody that can help you. The American College of Sports Medicine just introduced a new program where trainers can become certified now in obesity so that they can be more cognizant of patients with obesity and know that how to help them assess what they're able to do, what they can do without getting hurt, in the gym. So what to consider before and during the menopause transition? And also, this is similar to the transition that men might go through, during what I call the menopause transition, right? Which is this transition of aging, right? That can be associated with low testosterone, as Faris mentioned. But we really want to make sure, for men, for example, that it is from the testosterone. I think Faris did a great job highlighting that, right? That we want to make sure that it's not just because of the obesity that people have low testosterone, and then when they lose the excess body fat, their testosterone level will come up, but naturally, then you don't need replacement, right? For men. For both men and women, right, we want to bank muscle and bone now with regular resistance training. You cannot start resistance training too early as an adult, at least. I mean, we can discuss our pediatric population separately, but, getting in the habit of doing some resistance training, even body weight resistance training, things like push-ups on the counter in the kitchen, push-ups on the wall, right? Doing some resistance is important for everybody. You want to target that adequate protein distributed across the day, as Ferris mentioned, from a nutrition. And that's why our dietitians at knownwell do a great job of really helping our patients to. Many of our patients say, well, I don't think I need to see a dietitian, like I know what to do. But really, those dietitians, that's really what they're there to help us with, is to figure out how to do it, actually. Not just know what to do, but figure out how to actually do it. Give us some ideas of how we can get that protein. We're going to establish a baseline for you, right? Checking your waist circumference, your body composition, your lipids, your A1C, your LP little a, which is a certain type of lipid that we might check. So really, checking baseline levels of all these labs so we can really, get an idea of where you stand, when you get started. We want to set expectations, talk about the fact that the scale can underreport compositional changes, right? If you gain 10 pounds of muscle and lose 10 pounds of fat, your number on the scale doesn't change, but you're getting metabolically better, right? So we want to acknowledge that, and we want to, focus on, gaining health, not just losing weight. And as Ferris mentioned, protecting that sleep and addressing stress, right? Because cortisol, sleep, vasomotor symptoms for women, if they're having hot flashes, that's vasomotor symptoms, is a fancy word for hot flashes. If you're having hot flashes at night and you're waking up in the middle of the night, then you're not sleeping well. And if you're not sleeping well, then you tend to gain belly fat, right? So again, it's a vicious cycle that we can break by treating some of those symptoms. Next slide. And this is the menopause transition, a graphical representation of it, right? Female hormone levels, we don't measure them because they're so chaotic, right? We don't measure them routinely. We measure them in certain circumstances for certain reasons, right? To tell if maybe, why a person who's younger might not be having periods. That might be times when we check female hormones. But on a routine basis, you don't need your female hormones checked to know that you're going through menopause. This is a misnomer that's out in there in social media. Because if you look at that perimenopause time there in that orange, bracket, the hormones are all over the place. So if we measure them, it's not really telling us anything. We could measure it and it could be high and it's falsely telling us a story, because it's changing so rapidly and chaotically that measuring it doesn't really do any good. We see this decline in estrogen, progesterone, and testosterone. Testosterone's in the green there, but testosterone for women does not go down very rapidly throughout the menopause transition. In fact, postmenopausally, we can see a bump, an increase in our testosterone actually, as one of the binding proteins tends to go down in production. So again, the measuring these levels is not necessarily what needs to be done in women. In men, we do need to measure testosterone, right? Because it's a different story. We have different lab values that can correlate with, and for men, it's either low or it isn't, right? For women, because our hormones are cycling and changing all the time, measuring levels doesn't give us a good picture. Menopausal hormone therapy, right? That's what we're now calling hormone replacement therapy, or that, the new term is menopausal hormone therapy. That's estrogen alone or estrogen and progesterone, depending, right, on whether you have a uterus or not. If you've had your uterus removed, then you can take estrogen by itself. If you have a uterus, then you have to take estrogen and progesterone in order to, because if you take estrogen by itself and you have a uterus, then that can increase your risk of uterine cancer. So we don't want to do that. And when we're evaluating women for who should start on menopausal hormone therapy, Again, there's no routine checking of hormone levels. It's not necessary because we treat based on symptoms. We look at the symptoms you're having. We look at how old you are. We look at where you are in that transition, that your history, of your periods, that history, and that's really what's going to help us the most. So tracking your menstrual cycle, knowing where you are in that transition, really is what helps us the most. That versus any other level because we're treating based on symptoms, not based on just a number. We treat also based on stage of we treat differently based on the stage that you're in, right? So different treatment options for different stages. If you are still cycling and still having periods, adding estrogen or progesterone alone is not going to do the trick. If you're doing that in that perimenopause time when you're still having cycles and your levels, your ovaries are just pumping out random hormones, we need to actually give you oral contraceptive pills, which are a form of hormone therapy, right? To shut those ovaries off, tell those ovaries, stop doing this crazy, crazy time. And we need to shut those ovaries off, which also on top of that gives you hormones, right? Oral contraceptive pills are estrogen and progesterone. And so again, we give that back to you as estrogen and progesterone, but we just give it back in a different way than we do for women who are postmenopausal. And we weigh the risk and benefits. It's important to have an educated discussion with your clinician. This is not a one size fits all. You shouldn't be filling out a form on the internet and getting, medication in the mail in any way, shape, or form, whether you're a man or a woman. This should be something where you're having an informed discussion of a risk and benefit, with your clinician to know that because there are risks of any medication, of taking any medication, and risks of hormone therapy. So you want to weigh those risks and benefits, not just be taking it because you want to change in your body composition, for example. And this is kind of a busy slide, but the main focus of this is that testosterone therapy in postmenopausal women, um, a hypoactive sexual desire disorder, which is a decrease in libido, is the only evidence-based indication for testosterone therapy in women today. So we don't use testosterone therapy in women for just mood or energy or cognition. We don't use that for men either, for example. I mean, we really want to be treating something that's really something that's really affecting them, and we know that scientifically from the research we're going to get some benefit. We're weighing that risk and benefit, and we just don't have the current data, at least, to support adding testosterone therapy for women for other than what's called hypoactive sexual desire disorder, which is this, decrease in libido, and postmenopausal women as well. Perimenopausal women, we don't have any testosterone data, right? It really is reserved for postmenopausal women with really low libido that's really affecting their life and their relationships. And that is where we can try testosterone because there's no approved female testosterone replacement from a standpoint of for this for women in particular, right? And so again, because of that, we have to use off-label types of treatments, and we want to make sure we're doing those appropriately. So you shouldn't get any pellets or anything like that. Those are very unstudied, unregulated, and they can cause lots of side effects and not give you the levels. If we're doing testosterone therapy in women, we do it much like we do in men, which is typically with a topical testosterone that can be rubbed into the skin, and then the testosterone is absorbed that way. And that's our talk tonight is on hormones, both in men and women. Knownwell, if you're not a Knownwell patient already, is the preeminent nationally scaled provider of obesity medicine and metabolic health. Faris and I are leading the charge here at Knownwell. Yep, up, up, up. Yep. Next slide, Faris. And if you are not a patient and you want to become a patient, you can go to knownwell.co, or you can scan a QR code shown here. And, we provide many choices, non-stigmatizing approach. We have in-person or we have virtual visits, depending on where you live. We have care that really fits your life. It's going to be comprehensive, metabolic health care focused on this gaining health, not just losing weight. We're going to continue to see you in follow-up. We can see you anywhere in the United States because we have clinicians that are licensed in all 50 states. So if you can't see Faris or myself because of our licenses, we can hook you up with one of our partners to be seen, anywhere that you end up going. And it's covered by insurance, and we have some of the best outcomes. We're very proud of that. And so again, if you're not a known well patient, please consider joining us. And that's all we have for tonight on hormones and metabolic health. Let's see if we have any questions. We got a couple of questions in the chat, Faris. Um, oh, can you do a Zoom appointment from Illinois? Faris, I do not think you are licensed in Chicago
I
or in
am,
Illinois, but are you?
yeah, my license is only in Texas.
Yeah, so unfortunately, Ferris is only licensed in Texas. We have other amazing clinicians, though, licensed in Illinois. We have three clinics in the Chicago area. If you are in Chicago, um, we have three clinics in the Chicago area: Schaumburg, Westmont, and downtown in Lincoln Park. I guess it's probably not downtown for those of you in Chicago. Don't don't get mad at me. But Lincoln Park. And so, we have in-person clinics there with people that can, with clinicians that you can see. Or if you want to come down to Texas, yeah, and see Ferris in the clinic, you can certainly fly into Dallas and he'd be happy to see you wherever you
I
are.
I would love that. Yes, come over. Come over
I
to
know.
Dallas. There's a lot of good food here, healthy too.
Yeah, there you go. I know. Well, I don't know. I mean, it seems like there's a high level of barbecue in Texas, but
Yes,
maybe,
there's a
I'm
lot
a
of that.
barbecue fan myself. Protein, right?
Yes, lots of
From the
protein, lots of good protein too, good quality.
Well, that's we had another thank you for the great information. Known was amazing. Well, thank
Oh,
you so much. You're
thank
amazing,
you.
whoever that is, anonymous attendee. Um, and yeah, I guess, not a lot of questions, but Ferris, I think, you did a great job presenting how we evaluate, men in particular, for low testosterone. I think it's really important because, as you mentioned, when men tend to have excess body fat, the body fat produces estrogen, which
Yes.
then artificially lowers the testosterone levels. And then it looks like you have low testosterone. If you give somebody testosterone,
Mhm.
replacement, they would have excess testosterone as they lose weight and that their normal testosterone takes over.
Yes.
They would have too much, right?
I know. And you know what's also interesting? There's this whole aromatase enzyme because that's, over aromatization. So then the logic would say, well, why don't I just take an aromatase inhibitor and then call it a day? And because I thought about this and then I found that no, it's even if you suppress that hormone, they still didn't see improvement in like testosterone related symptoms. Like the treatment was still lifestyle, lose weight, burn fat, and reduce your visceral fat, which is really interesting to me.
Yeah, and also, right, I mean, the reason we're talking about this is there are risks of testosterone, taking
Yeah,
too much testosterone, right?
yeah, yeah. It's really interesting. We live in an interesting world.
And that's important too to know that, for men who may be younger, that have low testosterone, but even if it's, actually low, after we do testing and we confirm it, you know, we treat it differently depending on if you're still reproducing, right? Meaning or if you
Yes.
still want to reproduce,
Want,
because that's
yeah.
important. Because men who take extra testosterone,
Hmm.
that are still wanting to be fertile, the testosterone, the exogenous testosterone that we can give men for treatment, can make them less fertile. So we don't want to do that
Yes.
if you actually, want
Yes.
to have children. So we treat it a little differently with different medications instead of just giving testosterone
Yeah,
to
because
those younger people.
it suppresses that, I call it the testosterone system or the equipment.
Yeah, right.
Yeah.
The brain, gonad axis, right?
Yes.
Like that
Yes.
it suppresses. So we don't want to, like, yeah, we don't want to mess that up if people don't want to mess it up. So don't abuse testosterone if you're out there listening
No, please
and you're a
don't.
young person or older person.
Yes.
Well, the risk is really cardiovascular, right, for both men and women.
Yes.
I mean, the risk that we worry about with testosterone, extra testosterone, if it's not low, is that you can have an increased risk of cardiovascular events if you're taking too much. So that's why we want to, monitor levels and make sure that you're doing it correctly.
Yes. That's
Ferris,
awesome.
any other questions you can think of or anything, other points you want people to know
Um,
before we head
no,
out tonight?
my thing with all my patients, that I see is please exercise. Resistance training. We need that. And I watch your video of you doing the kettlebell. I was like, yes.
My son criticized me. He said I didn't have enough lower body movement. So it was all momentum. But anyway, you try to do your best, right? That's all you
I,
can do.
It's not easy. It's not easy, but it's one of these like necessary things. And then I felt like for myself, like it took me years to actually like get in the habit of just, doing this on a regular basis. So you have to learn your own, limitations and your niche. So that's what we do. We customize the plan based on the time you have, based on your history. What are you willing to do? We have a lot of resources we can share with our patients. So it takes time, and we've all been
And you
there.
can and you
Yeah,
can do it at home, you can do it at the gym, I
yeah,
mean, whatever, don't be scared, I guess, because so many people,
yes,
are nervous about it, don't know what to do. We can help walk you through that. It's something again, you can get a trainer. Some people end up, maybe starting at the physical therapist because again, maybe if they have some back issues or some issue that we can, have a therapist work with them. But it's really important just to get into any kind of routine that you can do regularly, and just do it, like Nike said.
yes, exactly.
To quote Nike.
Yes,
I
yes.
have this nice shirt that I like to wear, and it says that I jokingly wear with my trainer. It says just do it because it's a Nike t-shirt. And then underneath it says anyway. You could like just do it anyway. Like because I'm
Exactly.
always
Start
complaining.
somewhere.
I'm always complaining when I'm there. I'm always like, complaining. And she's like, rah, 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 little violins.
That's me also. Whenever I work out, I'm like, I'm tired. I want to go home. They're like, no, you can do it. You can do more.
You can do it.
20 more minutes.
And you feel so much better after you do it.
Yes.
I've always find if I could just get on the bike, or I like to do
Yes.
my Peloton, or I can just take a walk. And one thing we didn't mention, for those of you still listening, um, is that, there is some data from a metabolic health standpoint, especially after you eat, if you're physically active.
Yes.
Like, just even walking around your apartment or your workspace or your cubicle, or where, marching in your cubicle, wherever you're at, just, you can walk in place, you can walk around, but that movement after meals can be super helpful as far as metabolizing blood sugar. So don't discount that, right? Just get up and dance or get up and move because it really can help you metabolically.
Yes, absolutely.
All right. Well, Faris, thank you for this. This has been
Yes.
fabulous. And
Thank
thank you
you.
all for those that joined in and for the other people that are listening potentially afterwards as we post this online. Please, let us know if you have any questions. And for now, we will conclude our Known Well in the Know webinar. Thank you all for joining and please stay well.
Thank you, Angela.
Thank you, Faris.
Bye.
Bye-bye.